Uh, that will be we will be starting therapeutics with antihypertensive or hypertension treatment. You know hypertension, we have seen it in pharmacology, that what hypertension is, but we have not seen it more details. We will see these details here. As I told you earlier that whenever there are many treatments are available, then the continuous observations and the research, that is clinical research, is going on, and these results data which is collected, that is checked, that is verified, and on that basis of the data the further recommendations are issued by these scientists, by the experts, and these experts whatsoever they give, we call them two terms we have got, that is one is called as a guidelines, and on the basis of guidelines one chart like details are prepared, and these chart like details we call them as a algorithm. So you should remember all these things. What do you mean by guidelines and what are the algorithms? Guidelines are the standard sets of documents or standard set of instructions. These are given for given disease. So it includes everything. It includes the guidelines, includes that what kind of categorization of the disease can be there. Suppose there is a disease, then it has got grade 1, grade 2, grade 3, grade 4, whatsoever grading is there, or stage 1, stage 2, stage 3, or maybe class A, class B, class C. Different guidelines will have different kind of set, but these will specify, this will give that what kind of this stage is there, and if the person is in that given stage, then what should be the what are the criteria that makes the person into that particular stage, what are the consequences of this stage, and what is the best treatment for the given stage. So this all set of detailed documentation, that is called as a guidelines. In therapeutics, the biggest importance is a guidelines. In pharmacology, our biggest importance was mechanism of action and effect of the drug. Although pharmacokinetics we are studying, but here our biggest role is in therapeutics, what are the guidelines. So in hypertension we have seen so many classes. Here we shall see that what are the classes which are used in what kind of conditions. So where the grades will be changing, where in different grades what kind of drug can be preferred. So this is how there is a big difference in pharmacotherapeutics and pharmacology. So here we will be having various guidelines. Now let me tell you about hypertension, and as we go ahead you will be understanding various guidelines and their importance. So as we start with the hypertension, you will find that the hypertension guidelines, the most widely most accepted were known as a JNC guidelines, that is Joint National Committee guidelines, and these were developed by US National Heart, Lung and Blood Institute, that is NHLBI. But later and the latest one was JNC 7 guideline. So that was very famous. Many time examiners they used to ask what are the recommendation of JNC 7 guidelines. Okay, in 2013 JNC 8 has been developed and the recommendations were there, but JNC has not published guideline particularly, and majority of the JNC 8 guidelines they published the JNC recommendation independently, because JNC has not put it, and accordingly the another society is there which is working, that is known as a American College of Cardiology, that is ACC, American College of Cardiology, then American Heart Association and other societies. They came together and they made another recommendations, and they made it as a ACCHA hypertension guideline, and they are quite famous. They are I'll show you these guidelines also. So these guidelines are made, and these guidelines were given instead of JNC 8 guideline. So the last guidelines which are available from which were most widely most highly referred, they were JNC 7. I repeat, JNC 8 guideline, although prepared but not officially published by the NHLB, and because of that these were published by other people, and accordingly the last in 2007 which 17, which is the so which was the latest guideline, and on that basis of the guideline various categorization of the diseases and various treatment options were given. So let us go one by one, what are these and how various definitions are there, and how we are calling, or what kind of treatment are required for that. So they are given in very nice way in tabular formulation, that these are the differences, or these are the changes in the nomenclature or changes in the various words which are there. What were there earlier, when the blood pressure, systolic blood pressure is around 120 and diastolic pressure is less than 80, then we'll call it as a normal blood pressure. So JNC7 is also calling it as a normal blood pressure, and the 2017 ACC and AHA guideline, that is ACC means American Cardiology College of Cardiology and American Heart Association, they are also calling it as a normal BP. 120 to 129 when it is there systolic, and diastolic is greater than 80, then it is less than 80, I'm sorry. Systolic is 120 to 129 and diastolic is less than 80, then it was called as a pre-hypertension as per JNC7 guidelines. However, as per 2017 ACC AHA guidelines, it is called as a high BP. When blood pressure was, systolic blood pressure was around 130 to 139, and the diastolic or diastolic blood pressure is 80 to 89, means systolic is 130 to 39 is fixed, it should be more than 130, and diastolic can be anything, it can be 80, 89, like that. So in that it was called as a pre-hypertension, and this is called as a stage 1. Nowadays it is called as a stage 1 hypertension. Then when systolic blood pressure is 140 to 159, and or the diastolic is having 90 to 99, anything, suppose systolic is 120 and diastolic is 91, then still we'll call it as a stage 1 hypertension. It was called as per JNC7, but ACC-AHA calls it now as a stage 2 hypertension. And when the systolic is more than 160 or the diastolic is more than 100 mm of Hg, then the JNC7 was calling it as a stage 2. Here also it is called as a stage 2. So these are latest structure, latest guidelines, what shows various kind of blood pressure level and what they are called. So these are various classification. Beyond that, there are called as a hypertensive emergencies, hypertensive crisis, when the blood pressure still goes beyond that and which is not controllable, which requires immediate hospitalization and rapid therapy. Then these are the terms, we call them as a hypertensive emergency, hypertensive crisis, okay, malignant hypertension. These are various terms which we shall discuss in the due course of time. Now, what is to be done for the initiation of therapy? How the initiation therapy is done, at what condition therapy should be done, and what should be care taken for. So again, they have got various treatments for them, various data is collected, and on that basis the sort of this type of structure is called as a algorithm. Okay, so what it is, BP threshold and recommendations, they were done for treatment and follow-up. So if the blood pressure is normal, that is less than 100 mm, 120 mm and systolic and 180 mm of Hg diastolic, then and they are under risk, then what is no treatment is suggested. Only what is suggested is promote optimal lifestyle habits. That is, lifestyle habits are suggested. We shall, you just remind me if I forget, there are various diet things, and accordingly these diets are given, which minimizes the chances of various kind of diseases. So these are type of lifestyle. So some exercises, some lifestyle modification, changes in eating and dietary habit, then alcohol consumption, cigarette smoking. So these all things are known as a lifestyle changes. So first case, it is lifestyle changes, lifestyle habit changes, and check it in 1 year. In 1 year, if there is no change, then if it is still in normal condition, then no treatment is required. Then whenever the blood pressure is elevated, that is 120 to 129, where diastolic is 80 or less than 80 mm of Hg, again there is no pharmacological therapy is required. That is, they are made under class 1. So for class 1 there is no therapy is required. Only what is required is the lifestyle habits, and that changes. And but only thing is, the difference with first one is it was normal 120/80. Here the systolic blood pressure is more, that is 120 to 129. So instead of 1 year checking, it will be checked in 3 to 6 months. So this will be only difference. In both these cases there is no treatment is required. Then next is stage 1 hypertension, where blood pressure is 130 to systolic blood pressure is 130 to 139, or diastolic blood pressure is 80 to 89, and we can say that it can lead to problem, that is clinical cardiovascular disease, or estimated 10-year various atherosclerotic cardiovascular risk can be there, which will be greater by 10%. So therefore we need to treat this disease, and if these persons are having any familiar history of cardiovascular diseases or such kind of thing, then in this kind of patients, what treatment will do? If there is any clinical cardiovascular sign symptoms are there, or any familial risk is there, then we'll go for what kind of observation, and in other cases what you will be doing. So when it is there, no clinical cardiovascular and no familiar history, then again it is a class 1 non-pharmacological therapy, that is lifestyle changes, lifestyle, and here observe it in again 3 to 6 months. But if it is there, but there are chances, then again non-pharmacological therapy. Sometimes the antihypertensive drugs can also be classified. So here first time, after blood pressure has raised by this 130 to 139 and 80, so initially again here also there is no pharmacological therapy, and reassess it in 1 month. If it is there, then this BP lowering medication, that is antihypertensive drugs, we can give. Next is stage 2 hypertension, where blood pressure is more than 140 and diastolic is around 90 mm of Hg or more. Then along with that non-pharmacological therapy plus some of the antihypertensive drug we have to prescribe, and check it initially every month, and then if it is stabilized, if it is clear, then you can change it. Now which drug has to be given at what condition, that we shall be seeing one after another. I hope this much you are getting. That is what this type of things are called as an algorithm. Yes, no, then what should be done. So these are various kind of guidelines, and these guidelines are suggesting that if this is the situation, what has to be done. So these guidelines will give you various options, and on that basis of this they will be observing, and what kind of treatment, what kind of drug has to be taken, this will be there. Now we'll go for another one. These are called as a, I'll just change it. So this is actually the guideline. The earlier one which I was informing you was the basics or information about it. So see, this is the guideline which is given, that is called as a systemic review for ACC AHA, APA, these are various associations, and these have given the guidelines, and this is very prominent one. So these are the guidelines which are issued for prevention, detection, evaluation and management of high blood pressure. So you can see that this is again a very big document. So many scientists are involved in that, their names are there, big team is there. Then they put what these guidelines are made, what are the observations they have made, and on that basis what can be done, what kind of research they have conducted, what kind of data they have checked, and on that basis what guideline they are thinking, they are suggesting. So what their result says that there is a modest but significant improvement in systolic blood pressure in randomized controlled trials of self-measured BP versus usual care at 6 months, but not at 12 months. Means those who are measuring blood pressure at their own and they are trying to control, there is an improvement in that. Then, and it is helpful for doing the treatment. The second one is the systolic blood BP lowering to a target of less than 130 of mm of Hg may reduce the risk of several important outcomes, including risk of myocardial infarction, stroke, heart failure and major cardiovascular events. So these are actually the what we can say problems. When hypertension is continued, it is going unattended for long period of time, then the consequences of hypertension are, it can cause myocardial infarction, it can cause angina, it can cause cardiovascular failure, it can cause stroke, it can cause other any major kind of cardiovascular event. So therefore hypertension treatment is essential, and when we make the target of less than 130 mm of mercury, then these problems are minimized. The chances of having myocardial infarction, stroke, heart failure, major cardiovascular events will be lesser. No class of medications, example ACE inhibitors, angiotensin blocker, calcium channel blocker, beta blocker, was significantly better than thiazide and thiazide like diuretic as a first therapy for any outcome. This is very, very important. See, this guideline is published. I repeat now, you go back to pharmacology. In pharmacology, you have not given that much stress on thiazide because it is a diuretic drug. You will study it under diuretic class. Okay. So this chlorothiazide, and there are many such thiazide derivatives. These thiazide derivatives, they are considered as a diuretic agents. Diuretic means which causes increase in the urine output, and along with urine output there causes excretion of sodium and potassium also. So this, because of that they reduce sodium, because of that they decrease the water available, and apart from that they reduce the sodium. Because of this sodium is less, and whatsoever activity sodium is doing in hypertension, these all are reduced. So these drugs are found to be much better than any other. So what the study says that no class of medication, example ACE inhibitors, angiotensin receptor blockers, calcium channel blocker, beta blocker, these are the important drugs. These are the most important classes of the drug. We have seen that we have seen so many classes. Out of that, these 5 classes, ACE inhibitors, ARBs, calcium channel blockers, beta blockers and diuretics, these 5 are the most prominent one. Only these 5 are having more therapeutic role than any other classes which we have studied. We have studied so many classes. We have studied alpha 1 blocker like prazosin, terazosin. We will find that it is used in a rare condition when it is not controlled by these T. So this is what difference in pharmacotherapeutics and pharmacology. In pharmacology, anybody can ask you mechanism of action of alpha 1 blocker or reserpine or guanethidine. Here we do not use, we never find the name of guanethidine in hypertension and pharmacotherapeutics. So these are what the results says, and these are the results. These are giving after all the studies. So let us see about it. What are the results, and will not go for how they have made the studies. This is not important. This is what the guideline is saying, that is important. So these guidelines, they have made various categories of blood pressure, and on that basis they have made the categories. We have seen the categories earlier, that what are various categories and what these categories are meant for, what these categories can be there. So these are various studies in blood pressure, and they have studied so many reports about cardiovascular or blood pressures. Now let us go for various details about studies. What are the studies which can be there, what kind of graphs or what kind of algorithms are available for treatments. Just a minute. So this is a whole document is a guideline for that, and so many scientists, so many people were involved in that. Just a minute. I think this is a shorter version I have got. I'll go for the bigger version, and this has got all this data where the tables are there for various treatments. I'll just check. These patients are what they are done is this data will be checked, and then it was found that although these drugs, many drugs are there, may it be calcium channel blocker, may be ARBs, may it be the angiotensin receptor, this enzyme, angiotensin converting enzyme inhibitors, ACE inhibitors. So these drugs are very good. They can control hypertension. They bring it to the normal. Okay, they do not lower blood pressure. They bring it to normal. Okay, this thing is important. So they will bring it towards normal, and this blood pressure, once they bring it towards normal, or that is 120 to 80, and they are good in that. But the long-term studies that are called says if it is for the lifelong studies, wherever it will convert, it shows that those who are on the thiazide derivative or thiazide type of drug treatment was going on, they are having longest survival. or the mortality with cardiovascular disease or occurrence of cardiovascular diseases in this kind of patient is comparatively less than ARBs or ACE inhibitors. Or so this is what very important. This study shows that maybe initially some drugs are controlling blood pressure nicely, but still the drugs like thiazide, they are still best. And this study earlier also it was conducted around few years back, 8 to 10 years back. That time also it was found that the thiazide derivatives, they are the best treatment for hypertension. So we understood now that at higher level this is the best treatment. Okay. Then we know one more thing is, we have seen that hypertension can be either simultaneously or even though there is no hypertension, we have to give medications. What are these conditions? We have seen it in angina. To decrease the load, we have to give antihypertensive treatment. In CCF, in congestive cardiac failure, we have to give some of the antihypertensive drugs. Okay. So these all drugs, why we are giving? Why? Because we want to reduce the load of the heart, and where the heart is having difficulty in performing the task, we are trying to reduce it. We are reducing either preload or we are reducing afterload. So these two loads when we are trying to reduce, then what can be the impact, other impacts, and what can be the best drug in that conditions. So we have got various conditions, and in different conditions what medications are to be selected or what should not be taken. Example, in cardiovascular failure, when the heart rate has reduced or the force of contraction has reduced, the ejection, we measure it ejection factor. So when ejection fraction is reduced, in that cases we cannot use either calcium channel blockers or beta blockers. Okay, because if you remember treatment, we have seen that we have used some of the agents which causes increase in the heart rate, which causes increase in the pumping. We need such kind of agents. So in that cases we may not use calcium channel blockers, we may not use beta blockers. Then important is during pregnancy. There are many situations, either pregnant females, they have hypertension from the beginning, they are hypertensive and they are having pregnancy, or in certain cases the female after pregnancy or during pregnancy they get hypertension. That is known as a gestational hypertension. Gestational means the fetus which is in the uterus, fetus is growing, that is called as a gestation period. The whatsoever period the fetus is in the uterus, we call it as a gestation period. And during whatsoever hypertension is developed by a mother, that is called as a gestational hypertension. So in that case of gestational hypertension, we have to see, because the drug should not affect fetus when we are taking drug. When drug will be administered, drug, we have seen it in pharmacology, in pharmacokinetics, whether it causes placental barrier, whether it causes blood-brain barrier. If it is not required in brain and if it is causing crossing blood-brain barrier, then it will show CNS effects. And if it is causing placental barrier, means it will go to the fetus. It will be circulated in fetus tissues also, in fetus fluid also, and may show effect. It may not, it may be harmful, may not be harmful. But if it goes to fetus, then accordingly we have to see that what kind of medication has to be selected. And for that condition, what we have to do is, what we should do is, just a minute, I am getting a phone. This hypertension wise, I'll show you the various charts on that. Therefore, I ask you to go through pharmacology of all the antihypertensive drugs. So we can then plan it, we can then have that understanding that how these drugs are acting, how these drugs are selected, what are the basis on which they are selected, what, because some of these are having adverse effect, therefore they are not taken. Some of are they are having less efficacy in certain condition or some problems in certain condition. As I told you, beta blocker, calcium channel cannot be used during heart failure, etc. So all these things we have to take in account and plan all the medications. Now, actually, being a drug expert, the drug you are supposed to be pharmd people, drug experts. Then you should be aware about if it is a beta blocker is suggested, then which beta blocker you should use. Whether it should be atenolol, because we have seen there are many classification. If you remember in pharmacology, we have seen what were they. Example, those which can cross CNS, which cannot cross CNS in beta blocker, those which can have intrinsic sympathomimetic effect, or those which are having membrane stabilizing effect, those which are having nitric oxide releasing capacity. So many impacts we have seen. And when we have seen so many such impacts, then what should be better in what condition? This should be what our application. Actually, many time I tell you, I think I have not told you so far, but I used to tell one example, that whenever you go for any doctor, if somebody got some illness somewhere, either in family or somebody, even any person, then whether they go for checking what are the degree of doctor, no. The degree of doctor means from which college, how many percentage, whether university topper was there or no. No. What is seeing is what is the track record of the doctor, what doctor is doing. If the surgeon is there, how good the surgery is, how minimum complications are there, are known from the people. So people to people, when they say, when person goes there, they get well, and they get feedback, then people plan, and accordingly, not only doctor is highly qualified, same thing is applicable for advocate. Even the person who may not having very good marks, but he wins maximum cases, then people will go for the person. Same is the case with still another kind of people, that is those who may be illiterate, but the person are garage owner. When you go for two-wheeler repair, then you will not see what certificate the person is having, rather you will see that what kind of this mechanic is good. So everywhere what is respected is the knowledge. So this is what your knowledge is, and application of that knowledge. So that knowledge he may not able to write in answer paper, but they are able to select the proper method, proper thing at the time when the it is required. So that the doctor who is good, he select proper treatment for proper duration, and therefore people are getting well, they are having minimum problems, and the good prognosis. Prognosis means getting better, or relieving relieving from the given disease, whatsoever disease they were having. From that, when they are getting relieved, then we call it as a prognosis. So prognosis is good with that doctor, or the mechanic is repairing the vehicle in a good way. So all these things are there. These are known as the application of knowledge. So here you need the application of knowledge. So for that you must have knowledge. I told this, that you go through the hypertension. I am repeating this, that I want that you have read this topic, and then we are selecting the drug. So when we'll go for the next, whatsoever class of drug we shall be seeing, during that I expect you'll read the pharmacology, whatsoever various drugs we have studied in that. In hypertension, we'll go for various categories of drugs which are used. I told you on what basis these drugs are selected, what are the first preferences that we shall be seeing. I have told you about some of the preferences in various situations. Example, I told you in pregnancy, methyl dopa, labetalol, they are prepared. Then there are diseases or problem where there is a hypertension, we call it as a secondary hypertension. Example, pheochromocytoma. We have studied this during pharmacological classes, that which drug are better in pheochromocytoma, which drug we can use during CCF, which drug we can use during angina, which drug antihypertensive we have to use, after or post myocardial infarction, and which drug we are going to use in various conditions. That is, if the hypertension is not controlled by one drug, then what other next drug we are going to do, if what kind of drugs we are going for this hypertensive crisis or hypertensive emergencies, or this we call it as a malignant hypertension. So these are various terms which should be known to you. This should be gone through it, and accordingly what treatment we shall be doing. These are the important things. So please go through this. Please go through your basics. You will get some time in between, so you read it, and I'll suggest you to read even about other topics which are there.